Hi, everyone. Thanks for giving me an opportunity to talk today. So I'm Thomas Peterson. I'm an assistant professor at UCSF. I'm a data guy, and I'm here to talk to you today about big data and how it will affect your practice. At the risk of spoiling the whole talk, I don't really know. But I am going to give you an overview of what's out there and how you can use it right now, some of the drawbacks, and what you might expect in the future. Right, so I'm the director of a lab at a UCSF called the LCDHS, the Laboratory for Computational Digital Health Sciences. I'm a joint appointment here at the Department of Orthopedic Surgery and also the Baker Computational Health Sciences Institute, which means I am a data nerd. I actually don't have a practice, so full disclosure. I'm also a part of the San Francisco VA and various precision medicine initiatives. On the right here, I'm the director of the analytics core for the UCSF REACH for chronic low back pain. This is a core center for phenotyping patients, specifically for the opioid crisis, and I'm going to talk a little bit about that in the future. And I have no relevant disclosures, just want to let you know. So one of the things we work on is large data sets. So this is the University of California Health Data Warehouse. This was spearheaded by the Baker Institute here at UCSF. We harmonized all the electronic health records from the 6 major academic medical centers at University of California. As you can see here, it spans all over the coast and also outside of California as well. We have things that you might expect, like demographics, age, gender, primary care population versus non, social vulnerability index, which tells you a little bit about the neighborhood in which they live, so economic conditions, average income, education level, those types of things. We also have information about their insurance, and as you can imagine, any kind of comorbidities, anytime they interacted with the healthcare system at all, being even email or phone calls, this all goes in here, and this has coding so that you can access the data very easily and draw inferences that might help you in your practice. So this is a retrospective data set, right? And we have the ability to look at larger healthcare systems, connect our database to this OHDSI, the Odyssey network. This comes from over 18 different countries, more than 369 million patients from outside of the United States, 133 different databases, patient-level data, right? So we're looking at electronic health records, administrative claims, different hospital systems, registries, health surveys, and biobanks. So this is all data that gets collected while you do your practice. This would be retrospectively collected data, right? So what we're looking at is the exposure factors that happened in the past, right? So as a researcher, you want to know what data is out there and how can I learn about specific circumstances that you want to know to improve care for your patients, right? So like we just talked about, electronic health records, huge databases there. They're a little bit more detailed than things like administrative claims databases or nationwide surveys. Specifically, they'll have clinical notes, free text clinical notes, and clinical images, right, where these might not have those. We can also look at prospectively collected data, right? So, for instance, I mentioned that I'm the director of the analytics core for UCSF REACH, where we're deeply phenotyping patients with chronic low back pain. So, we got a big grant, like $29 million to, prospectively collect thousands of patients, looking at their clinical presentation. We give them Apple Watches to look at their movement. This is pretty much the only reason I own this thing, so I can point at it up here. We look at their pathophysical phenotype, so their MRIs. We also have specific weighted MRIs to look at their the body fat percentage of the paraspinal muscles. And we also look at biobehavioral phenotypes with a whole mountain of surveys and also fMRI data, right? A lot of this data wouldn't be available in the retrospectively collected data, so we had to do a prospective study, right? So what I wanted to show you here is there's tons of data. Some of it might be considered big data, right? So things on the left here, retrospectively collected data. Or it might be considered small data, but it might be deeply phenotyped, right? So the data that we're collecting prospectively is going to have a lot more information, more deep phenotyping than the retrospective data, right? So when we're moving forward with these things, remember that the databases we have available, sometimes they have more data or less data, or they might be deeply or more shallowly phenotyped. For example, the two databases that we're collecting here at UCSF Reach, which are the prospective data sets, these are the comeback and back home data sets. The back home data set is a digital cohort, which means that we follow them prospectively. We get additional information that you wouldn't get from the electronic health record, right? So compared to electronic health records or large claims databases or nationwide surveys like CMS Medicare or NHANES, you're going to have a much smaller cohort size, right? But the depth of the phenotyping is much deeper. Your outcome metrics are more detailed, right? So if you wanted to know, say, what is your PROMIS score going to be after surgery in a year, that's going to be very hard to get from the electronic health record unless you were actively collecting it through collection systems, which typically doesn't happen in electronic health records, right? So the drawback is that these smaller data sets that are more deeply phenotyped are quite expensive to use in research. Whereas the EHR data set and the NHANES data set are basically free for us because they exist, right? So just an idea of like sort of the general world of the big and small data sets and why some of those small data sets might actually be big data sets. So what we can do is we can look at biomarkers that'll help categorize patients, right? So one patient might respond to a specific treatment or might have a specific phenotype that would be treated in a specific way, while another patient might respond to another one, right? And that's why you want to get all the data you can, the largest data sets possible, with the most specific, detailed information that you need for your specific task, right? This is a tool that you can use right now, right? This is the ACS NSQIP surgical risk calculator. I don't know if you guys have seen this before. I don't know if it's changed your practice yet or if it ever will. But this exists out there on the internet. This is a drop-down calculator. You know, you can you take your mouse and you put, does this patient have diabetes? You know, are they a current smoker? What's their ASA class? Those types of things. And you know, you can actually optimize a patient for surgical risk, right? So you can say, if you were to stop smoking, then you might get this better outcome. If you were to lose weight, you might get this better outcome. And you know, depending on the type of surgery or the type of intervention you're doing, you might have different items that you would optimize pre-intervention to help the probability of a patient having a better outcome, right? So here we're looking at length of stay and discharge disposition, right? So there's obviously a lot of complications in these types of surgeries, and you can use these tools for a specific patient to say, you have this specific risk for this adverse outcome, or you're going to stay in the hospital for this many days. And this can help not only patients and clinicians prepare for the surgery more in a more tailored way for that patient, but it can also help control costs, right? So extended length of stay in hospital, over $100,000 typically following a spine surgery. Rehabilitation services, so do they go to a skilled care facility afterwards or not? Can account for up to 30% of the cost of care, right? So optimizing pre-surgery for it, to avoid these negative outcomes is very beneficial, right? And so you can see on this calculator, it'll tell you down the bottom what the likelihood of this patient is undergoing this surgery to be discharged to a skilled care facility, have sepsis. There's a bunch of other ones here too that we're not really looking at, and also length of stay, right? So it's possible to use this today to optimize your patients, not just for spine surgery. This does all kinds of different surgeries. So we wanted to test this in our patient population. You know, can we use these tools to actually accurately predict these things in our database? Because this is built off of a very large database from the American College of Surgeons, many different types of surgeries, not just spine surgery here, right? So if you're getting a surgery for on your heart, is it actually going to improve your model when you're looking at predicting for spines? Maybe not. So we wanted to set out to make one of these ourselves. So we used the electronic health record, and we identified 3,678 patients undergoing spinal fusion surgery. We isolated them at the date of the surgery. So we looked at variables before or on the day of the surgery, looking at demographics, variables describing the operation. And we wanted to know how long does the patient stay in hospital after surgery, and are they discharged to a skilled care facility or not? So what we did is we broke up the data into training and testing, and we put these through the NSQIP calculator. So now we know what NSQIP says for this subset of patients, and we want to see, can we train a model using our in-house data to beat NSQIP, right? And is NSQIP doing well? So this is the results for predicting length of stay after spinal fusion surgery. On the bottom here is the NSQIP calculator, on the top is our in-house model. So you can see that we're doing a lot better than the NSQIP calculator. The Peterson's correlation coefficient is 0.4, and we're getting 0.55. There was another model that was out there that looked at a correlation coefficient of 0.5, but it was using additional data that wasn't necessarily in the EHR. But we did what appears to be better than they would have calculated on their own data. Right? So this is just a plot, and you can tell the NSQIP, it does work, but if you tune it using your own patients, you're going to get a better outcome technically. Similarly, we look for predicting discharge disposition. The NSQIP for predicting who will and won't go to a skilled care facility achieved an area under the ROC curve of 0.75, which is good. And we created a model that achieved 0.787, which is significantly better, right? So again, NSQIP can help you predict patient-specific outcomes for your patients that you can use to optimize prior to surgery to anticipate better outcomes, but you can actually make tools in-house that will do a little bit better, right? And in the future, actually, we're expanding to new data sets. We're partnering with the University of Utah, AO Spine, and Vanderbilt University, and the SPORT trial to make a model that is specific to spinal surgery and will work across different data sets, right? And it's also important to know that in the future, you're not going to go to a drop-down menu, some website, and put your patient's data in there. This might not even be allowed, right? But there's a tool called FHIR. This is the Fast Healthcare Interoperability Resources. This is a system that securely connects with the electronic health record, right? So things that you can use it for are dashboards, apps, wearable devices. And these are things that can go into a machine learning model that you can use to predict patient-specific outcomes. So the more kinds of data that we can collect and put in these models, the better, right? These can be used by not only patients to help optimize themselves before surgery, but also by providers and payers to better anticipate patient-specific outcomes, right? So overall, more data, more types of ways to use them, honing machine learning tools to your patient population. There's an opportunity to use tools that are out there already, but one day these will probably just appear in your electronic health record, and it will tell you this patient has this likelihood of having this adverse outcome, and it might even suggest ways that you can lower that risk of outcome, such as modifiable factors like BMI, smoking, hyperlipidemia, those types of things. So thanks, everyone, and I want to thank everyone, all my collaborators at Baker Institute in Orthopedic Surgery and Backpack and Heal.